Welcome to the deep dive. Today we are focusing on a really core text in mental health nursing, a chapter all about crisis and disaster management. And it feels incredibly timely, doesn't it? I mean, even the authors were revising this stuff during the pandemic, a massive global crisis itself. So our sources dive right in. What happens when life just throws you completely off balance?
Yeah.
A crisis is defined as this major disturbance. It's caused by stress, maybe a threat, and it just shatters your internal equilibrium, your homeostasis.
Yeah,
And when those coping mechanisms you normally use just fail you, well, that's when you hit disequilibrium.
exactly. And that failure state is where nursing comes in. Our goal here is to figure out what makes for a successful crisis outcome. Research points to three really essential factors. First, how realistic is the person's perception of what happened?
Okay.
Second, do they have enough situational support, people, resources around them?
Right.
And third, do they have adequate coping mechanisms, tools they can actually use?
That first one perception, it seems huge. It shows the crisis isn't just the event itself, it's how you see it, right? Like that classic example in the text, the 10-year-old twins whose parents are divorcing, Amy. Her grades tank, she's withdrawn, sees it as total disaster.
Precisely. Amy's in crisis because her perception is just overwhelmingly negative. But Annie, her twin, same divorce, but she's thinking, cool, new bedroom, I can paint it purple.
Right.
The stressor's identical, but Annie's perception lets her coping mechanisms work. She avoids that disequilibrium, and that perception, it totally dictates the intervention needed.
Okay, so let's get into the foundations then. Where did all this crisis theory start?
Well, to really get it, you have to go back to Erick Lindemann's work. It followed the Cocoanut Grove fire in 1942, just a horrific tragedy.
Wow, yeah. He studied the survivors, the families. What was so groundbreaking about what he found?
It was revolutionary for the time. He saw these immediate reactions, intense grief, anger, being disorganized, even physical symptoms. And he said, wait, these are predictable and normal responses to massive loss.
Not signs of mental illness.
Exactly. Before him, people often viewed that kind of acute grief as like a mental breakdown. Lindemann showed it was normal grief behavior. And crucially, he argued that quick, brief therapy could actually prevent serious, long-term personality issues.
Ah, so that idea that intervention could stop things from getting worse, that paved the way for others.
It really did. Gerald Caplan built on Lindemann's work. He emphasized that having personal and social resources, those supports we mentioned, is absolutely key to recovery. He took it from just grief support to a whole crisis intervention model.
Okay.
And the framework often used now, especially in acute settings like an ER, is Roberts' 7-stage model of crisis intervention.
You don't need to memorize all 7 steps right now, listening in. But the structure itself is important, isn't it? It's directive, it's time-limited, sort of a roadmap.
It is. And the critical takeaway from that model is where it starts. Rapid assessment. Establishing rapport quickly, yes, but immediately checking for safety, lethality assessment, self-harm potential. You do that first.
Or anything else.
Before anything else. Then you move quickly to figure out the main problem, deal with feelings, and start building an action plan.
Got it. So that structure helps guide the care plan. But first, we need to know what kind of crisis we're facing. The text breaks it down, right?
Yes, into 3 basic types, which is really crucial for planning patient-centered care. First up is the maturational crisis, sometimes called developmental. This happens when someone reaches a new, predictable stage in life, and their old ways of coping just don't work anymore.
Like leaving home for college, or
Yeah.
retiring, getting married.
Exactly. Things like that. Think about Erickson's stages, And it's important to remember these normal transitions can get seriously derailed by other things, like substance abuse, for instance.
Makes sense. Okay, what's the second type?
Second is the situational crisis. This comes from external events that are usually pretty distressing and, crucially, unanticipated. They're specific to the individual.
So like losing your job out of the blue, or a sudden death of a loved one, a bad diagnosis.
Precisely. Unexpected, throws your life into turmoil.
Okay, and the third?
And the third type, these are the adventitious crises.
Yeah.
These are the really big ones. Traumatic, external events that are just completely outside the scope of everyday experience, often large scale.
Like natural disasters, earthquakes, floods.
Yes, or acts of terrorism, major accidents like plane crashes, or even intense personal violence like rape or assault. These are the events that are most likely to trigger or worsen things like acute stress disorder or PTSD.
Wow. And it's possible, even common, for these to overlap, right?
Yeah.
That example of the 51-year-old woman, she's dealing with menopause, which is maturational.
Right, a normal developmental stressor.
And then her husband suddenly dies of a heart attack. That's situational, layered right on top.
Exactly. And that combination, the pressure just multiplies. It can completely overwhelm someone's ability to cope. It's exponential.
Okay, so that leads us into how people actually respond when they are overwhelmed. Kaplan outlined phases for this, didn't he?
He did. Caplan described 4 distinct phases that show the path toward disorganization when coping fails. It starts with phase 1. You're exposed to the stressor, your anxiety goes up, and you start using your usual coping methods. Pretty standard response.
Okay, makes sense.
Then comes phase 2.
Uh-oh.
Your usual coping isn't working, the threat is still there, anxiety keeps climbing, and your functioning starts to get disorganized. You begin trying different things, kind of trial and error.
Right, grasping at straws a bit.
Exactly. Then we hit the really critical point between phase 3 and phase 4. In phase 3, trial and error fails too. Anxiety skyrockets to severe or even panic levels. The person might resort to automatic relief behaviors, running away, shutting down, maybe making a desperate compromise.
But if that doesn't work?
If they can't resolve it there, they fall into phase 4. That's when the anxiety just completely overwhelms them. It can lead to serious personality disorganization, maybe profound confusion, sometimes violence towards self or others, suicidal thoughts.
And that slide into phase 4 is precisely why nursing intervention is so critical. We know crises are time limited, right? Usually about 4 or 6 weeks.
Typically, yes. They resolve one way or another in that time frame.
So our intervention strategy has to be immediate, goal-directed, and focused on getting the patient back to at least their pre-crisis level of functioning. That's the minimum goal.
Absolutely. Or potentially even helping them grow from the experience and function at a higher level. But baseline is the minimum.
Okay. And before we even think about coping skills or anything else, assessment starts with
Safety. Always safety first. Because people in crisis can be deeply disorganized, maybe impulsive. You have to ask directly about self-harm or harm to others.
So questions like, have you thought about hurting yourself? Or do you feel like you can keep yourself safe right now?
Yes. Direct, clear questions about lethality. You assess that immediately.
Okay, safety first. Once that's addressed, we circle back to those 3 core assessment areas you mentioned earlier. Let's use that case study, Madison, the 25-year-old abuse victim in the ER.
Good example. So first, we assess her perception of the precipitating event. We need to know her view of why she's here now.
Asking things like, what brought you in today? Or what's happening right now that led you to seek help?
Exactly. Focused, present tense questions. Madison reveals she's terrified her wife is going to kill her. We validate that fear immediately. Tell me what feels so terrible. Let's look at this together.
Okay, then what's next?
Next, we assess her situational supports. Who does she have? Family, friends, community agencies. Who can she lean on?
And in Madison's case, the assessment reveals her wife actively blocks those supports, right? Through jealousy and control.
Yes. Her support system is essentially cut off.
So when that happens, is the immediate nursing challenge maybe less about, like, cognitive therapy and more about practical advocacy, removing the danger?
Oh, absolutely. The intervention shifts immediately. We might need to involve social services, look into safe housing options, maybe even protective orders before we can effectively work on coping skills. Safety and practical support come first.
Got it. And the third assessment area?
Coping skills, what does she usually do? What helps? What doesn't? We need to know her patterns. Is it talking, journaling, exercise, positive coping? Or is it overeating, drinking, withdrawing things that are ineffective or harmful?
And Madison identifies talking as helpful.
Right, which becomes a key part of the initial plan. Maybe setting up structured daily check-ins or connecting her with a support line immediately. We build on what works for her.
This sounds incredibly intense for the nurse, too. The text mentions self-assessment for us.
Yes, and it's crucial. We have to recognize our own triggers. Maybe a patient's situational crisis hits too close to home because of a loss we've experienced. We need that self-awareness.
And especially after huge events like adventitious crises.
Definitely. For those big, overwhelming disasters, formal staff debriefing isn't just helpful, it's essential for preventing burnout and secondary trauma among responders.
Makes sense. Okay, so moving into interventions. What are the immediate goals?
The 2 initial psychosocial goals are always, 1, patient safety. That might mean external controls if someone is acutely suicidal or homicidal. And 2, anxiety reduction.
Because you can't really learn new coping skills if you're in a state of panic, right?
Exactly. You have to bring that severe or panic level anxiety down first before any effective teaching or problem solving can happen.
And when we work with the patient, what's the underlying approach? The text mentions some key assumptions.
Right. We operate on the assumption that the patient is ultimately in charge of their own life and decisions, even in crisis. They can make choices.
So it's a partnership.
It's absolutely a partnership. The nurse is an active partner, often quite directive, focusing intensely on the immediate problem, the here and now. We're also an educator, an advisor, a role model for coping.
Okay. And we structure this support using levels of prevention, similar to public health models.
Yes, the three levels are very useful. Primary prevention aims to reduce the incidence of crisis altogether. It's about promoting mental health before problems start.
So that's things like teaching stress management, problem-solving skills, assertiveness in schools or community settings.
Exactly. Building resilience in the general population.
Then secondary prevention.
That's the intervention during the acute crisis. The goal here is to prevent prolonged anxiety or disability. This is what happens in ERs, clinics, on crisis hotlines, or with mobile crisis teams. It's immediate containment and support.
Okay. And tertiary prevention.
Tertiary provides the long-term support after the acute crisis. It's about rehabilitation and helping the person maintain the best possible level of functioning. Think sheltered workshops, day hospitals, ongoing support groups, maybe those peer-run warm lines.
Speaking of support after trauma, especially for groups, Critical Incident Stress Debriefing, CISD. That fits here, right?
Yes, CISD is a great example of tertiary prevention aimed at groups, particularly first responders or others who shared a traumatic experience.
It's quite structured, isn't it? 7 phases.
It is. They go through phases like introducing the process, talking about the facts, sharing thoughts. But the really powerful part is often the reaction phase.
That's where they talk about the worst part.
Yeah, participants are encouraged to share what was the worst thing about this incident for you. It allows for expressing those really strong emotions in a safe, validating space. Sort of an emotional release.
And then it moves into teaching.
Right. The teaching phase follows, where the facilitator normalizes the stress reactions, explaining that things like nightmares or feeling jumpy are expected and offers stress management techniques and coping strategies. Then there's a reentry phase to wrap up.
Okay, so that leads us to some of the modern ways we deliver crisis support. We have the call lines.
Right, crisis call lines, hugely important. We've seen the transition to the nationwide 988 number, offering 24/7 confidential immediate support and assessment, especially crucial for suicide prevention.
And distinct from those are warm lines.
Yes, warm lines are different. They're explicitly not for acute immediate crisis. They're more for prevention, for people needing support before things escalate. And importantly, they're often staffed by trained consumers, people with lived mental health experience offering peer support.
That peer support element is key. Then there are the teams that come to the person.
Exactly. Crisis intervention teams, or CITs. These are mobile units, typically licensed clinicians, maybe peer specialists too, who travel to the person's location, home, community, wherever.
And a major goal there is diversion, right? Keeping people out of emergency rooms or jail if possible.
That's a huge goal. Diverting individuals from unnecessary hospitalization or incarceration by providing immediate on-site mental health support. Many CIT programs partner closely with law enforcement, providing specialized training for officers responding to mental health calls.
And if someone needs a bit more than mobile support, but maybe not full hospitalization.
That's where crisis stabilization facilities come in. They offer short-term care, usually less than 24 hours, designed to rapidly de-escalate a situation, stabilize the person, and connect them with follow-up care. Again, often avoiding a longer hospital stay.
And one more tool, more proactive. The Psychiatric Advance Directive.
Yes, the Psychiatric Advance Directive Plan. This is something a person creates when they are well. It outlines their treatment preferences, names support people, basically says, if I'm in crisis again and can't make decisions, here's what I want. It empowers the individual even when they're vulnerable.
Okay, that covers individual crisis really well. Let's shift gears slightly to the bigger picture. Disaster response management. Large-scale adventitious crises.
Right. And the text emphasizes this is a global issue. Building resilient communities and assessing risks are key. Nurses are absolutely vital players in disaster response and, importantly, in the long recovery efforts.
The framework used in the U.S. comes from FEMA, right?
Yeah.
The 4-phase disaster management continuum.
That's the one. It starts with mitigation, basically, prevention. Taking actions beforehand to lessen the impact if something does happen. Building codes, zoning laws, things like that.
Then preparedness. This is the planning phase. Setting up warning systems, having emergency operating plans ready, stockpiling supplies, doing drills.
Exactly. Then comes the response phase. This is the immediate aftermath. Activating emergency plans, search and rescue, setting up shelters, providing immediate aid.
And the last phase, recovery. This often seems like the longest and maybe most complex part.
It often is. Recovery involves restoring the community, rebuilding infrastructure, providing ongoing support. It can take months, even years, and it happens alongside normal life resuming. This is where long-term mental health needs really surface and require sustained attention.
And the coordination for these large events, especially after 9/11, became much more structured.
Definitely. The Department of Homeland Security, DHS, now coordinates the federal response. And they use systems like the National Incident Management System, IMS, and the Incident Command System, ICS.
NIMS and ICS. Basically standardized ways for everyone to work together.
Pretty much. The core idea is that all responders, fire, police, EMS, public health, volunteer groups, nurses, use the exact same terminology, the same organizational structure, the same clear chain of command during a large-scale incident.
So it cuts down on confusion when things are chaotic.
Absolutely. It ensures everyone speaking the same language, knows who's in charge of what, and can coordinate effectively, especially when local resources are just completely overwhelmed. Nurses, with our adaptability and assessment skills, are crucial for making these coordinated plans work on the ground.
Okay, so let's try to wrap this up. This deep dive really underscores a few key things. Crisis is acute, right? Short-term, 4 to 6 weeks usually.
Yes, and it's always a turning point. It presents danger, but also an opportunity for growth.
And then we categorize them. Maturational, situational, or those big adventitious ones. The goal is always returning the person to at least their pre-crisis functioning level.
And your role as the nurse is active, it's directive, focused squarely on the present problem, the here and now. You're a partner and educator.
And always prioritizing safety first, then anxiety reduction so coping can actually happen.
Couldn't say it better. Safety and anxiety reduction open the door to everything else.
Okay, so here's a final thought for you, our listener, to chew on. We talked about how individuals come out of a crisis functioning at a higher level, the same level, or maybe a lower level than before. Now think about that on a community scale. When a major disaster, an adventitious crisis hits an entire town or region, a flood, a wildfire, maybe even like the pandemic, that community also emerges changed. What factors do you think, societal ones, psychological ones, leadership, resources, what pushes an entire community toward emerging at a higher level of functioning, more resilient and connected than before after experiencing immense shared trauma? Something to think about.
That's a powerful question.
Thank you so much for joining us for this deep dive into crisis and disaster nursing principles. We really hope this knowledge helps support you wherever you practice or study.